Okay. Good afternoon. I'm at-large Councilmember Christina Henderson, Chairperson of the Committee on Health. Today is Thursday, April 6th. The time is 12:04 p.m. Today we are live and in person, the Council Room 412. We are also broadcasting via the Zoom internet platform and on cable channel 13, as well as on my YouTube page at CMC Henderson. I'm calling to order this meeting of the Committee on Health for the second part of the FY24 hearing for the Department of Behavioral Health's proposed budget. Last week, we held a hearing for public witnesses, and today we will hear from Dr. Barbara Bazaran, Director of the Department of Behavioral Health. DBH provides prevention, intervention, and treatment services and supports for youth, children, and adults with mental and or substance abuse disorders, including emergency psychiatric care and community-based outpatient and residential services. DBH serves eligible categories through a network of community-based providers and government services. They also manage the district's school-based mental health and behavioral health programs, as well as operates St. Elizabeth's Hospital, the district's inpatient psychiatric facility. DBH serves district residents based on the belief that they can recover from mental and substance abuse disorders and live healthy and happy, successful lives. The COVID-19 pandemic exacerbated the existing crises that many residents were facing, and at a time that made it more difficult for DBH and their partners to provide critical services. Last week, we heard from nearly 60 public witnesses, including students, parents, community-based providers, interested community members, and advocates. They discussed the need for increased resources for school clinicians and behavioral health staff, substance abuse and gambling prevention, treatment and recovery, early intervention, and crisis services. I don't see any of my colleagues. Okay. Can you change the view setting on so I can see them? Two of my colleagues are here. I don't know who got here first. So I'll just go with So I'll go with Councilmember Parker first. Councilmember Parker, if you have an opening statement, if you could just limit it to 5-ish minutes.
Thank you and good afternoon, Chairperson Henderson. Really looking forward to today's conversation. We heard a lot yesterday through public witness testimony about the ways in which providers are struggling to meet the demands on the ground. I'm hoping that Dr. Bazaran will speak to that. And we know that there is a lot more that we need to do, even as our budget is contracting. One of the things I'm especially interested in learning more about is the moratorium on mental health providers that is in place in the district. Through our conversation with Deputy Mayor Turnich, it seems as though there's a question across government why this moratorium is still in place. And then the last thing I just want to say is I do applaud and commend Dr. Bazaran and her team for navigating the agency through what is continuing to be a very difficult time. And so in addition to the questions and pushes on the budget, I also just want to recognize the hard work that is going into addressing the behavioral health needs of district residents. So with that, I turn it back over and looking forward to the discussion.
Thank you, Councilmember Parker. Councilmember Nadeau.
Thank you, Madam Chair. You know, I think we are very lucky to have such a robust offering of services in our Department of Behavioral Health. And I thank Dr. Bazaran and her whole team for the work that they do. I've worked especially closely with the CRT, and they are incredible, although I would argue that they are understaffed and need to be utilized more frequently in certain areas. So I'm very glad to see a new sobering center in Columbia Heights included in the capital budget. This is something we've been trying to do in Columbia Heights for several years. Siting had been an issue in the first round of RFPs. And so having those funds to now renovate a district-owned property should make it easier to get this done. It's something that we've been working on for a long time, and it's a site that we've requested in the past. So I thank the executive for that cooperation. I will be asking some questions today in relation to the work that I've been doing in a pilot that we want to expand. We've seen significant success with dedicated outreach workers focused on the plaza in Columbia Heights. And I want to make sure that this work is built on and that we can start talking more about place-based interventions for our street outreach. And to that end, I'm disappointed the mayor did not fund a request I made alongside Councilmember Pinto for place-based substance abuse intervention on the 700 block of T Street Northwest in Shaw. We've seen tremendous success in Columbia Heights. It's clear that DBH's existing model isn't working for spaces like the plaza and the issues on T Street near Howard Theater, where we have persistent drug use and a need for services. Instead, Columbia Heights outreach funding wasn't renewed. T Street remains unfunded. So with my time today, I want to understand what are DBH's plans to address substance abuse in these spaces, and how can we secure more funding for that place-based work? Thank you, Madam Chair.
Thank you, Councilmember Nadeau. Dr. Bazran, before you would begin, I'll ask that you and everyone on your team who might answer questions today to be sworn in. So if you can all please raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Thank you. Please begin, Dr. Bazran.
Good afternoon, Chair Henderson, council members, and council staff. I am Dr. Barbara J. Bazran, Director of the Department of Behavioral Health. I'm pleased to testify before you today on Mayor Muriel Bowser's proposed fiscal year 2024 Fair Shot budget that makes the necessary investments to promote and sustain the district's comeback, including increased investments in behavioral health care. With me today is Adrian Reed, Agency Fiscal Officer, Michael Neff, Chief Operating Officer, and Mark Chastain, Chief Executive Officer at St. Elizabeth's Hospital. Under the leadership of Mayor Bowser and the guidance of Deputy Mayor Wayne Turnage, DBH supports healthier, stronger communities by working to prevent the onset of mental health and substance use disorders and providing a range of community-based treatment services and recovery supports. DBH also provides crisis services, operates adult and child urgent care clinics, and manages St. Elizabeth's Hospital for psychiatric inpatient care. Mental health is health. A person's mental health can change over time depending upon many factors and changing circumstances, such as the pandemic. Gun violence and safety concerns place additional stress for too many in our community. When demands placed on a person exceeds their resources and coping abilities, their mental health could be affected. Losing a job, caring for a relative, or experiencing sustained trauma can lead to poor mental health. Mental illness and poor mental health are not the same thing. A person diagnosed with a mental illness can have periods of mental well-being, and a person can experience poor mental health and not have a diagnosis of mental illness. More than 41,000 residents of all ages receive treatment and recovery services through the Department of Behavioral Health. During the pandemic, with increased investments supported by council, DBH met the increased demand with enhanced or new services. In FY22, more than 41,560 people received mental health treatment through DBH, a 24% increase from FY20 during the height of the pandemic, driven in part by greater use of telehealth. There also was a 6% increase in the number of people who received substance use disorder services compared to FY21. Mayor Bowser's proposed budget for DBH keeps pace with the increased need and ensures that residents can get connected to the care they need by phone, home, in school, or in the community. In addition, the proposed FY24 budget continues support started during the pandemic to meet the needs of residents with moderate or mild depression and anxiety. A 24-hour mental health hotline to talk with a mental health specialist is free to any resident. A Wellness Wednesday virtual forum supports parents and caregivers, and a Healthy Teachers DC virtual forum supports educator wellness. In addition, the FY24 budget continues support for expanded crisis services, including the 988 Suicide and Crisis Lifeline. Since the launch of the new 3-digit number in July of 2022, calls have increased by 18%. The proposed FY24 budget supports the transformation work underway with our partners to provide residents with high quality, more equitable, culturally insensitive public health and culturally sensitive public health system, and to address the mental health needs of all residents. This transformation supports our work with the Department of Healthcare Finance to prepare the provider network to operate in a managed care environment. Bringing behavioral health services into Medicaid managed care programs support better care coordination and case management essential to whole person care to achieve optimal health. The promise of integrated care is healthier people living longer, more fulfilling lives. As the state authority, the Department of Behavioral Health would establish standards and policies for behavioral health care delivery, monitor quality of care, promote behavioral health education and disease prevention, and measure population health outcomes. I will now present an overview of the proposed FY24 budget for DBH. We provided responses to the committee detailed pre-hearing, the committee's detailed pre-hearing questions, and we appreciate the collaboration with committee staff. DBH's FY24 budget formulation is driven by several factors: the integration of behavioral health care and primary care into managed care, additional reimbursable services, rate adjustments, and provider training and technical support. Other key drivers of budget formulation were to maintain essential services such as school-based behavioral health, early childhood, and substance use disorders. The mayor's proposed budget for DBH reflects these priorities. The proposed FY24 gross operating budget is $385,143,814, which is a 2.2% increase over the FY23 approved budget. The increase is primarily due to an $8.6 million increase in local funds. The proposed FY24 capital budget is $12.1 million, $2.6 million for St. Elizabeth's Hospital facility projects, and $9.5 million to support the opening of a second stabilization and sobering center. I will highlight and share a few elements of our budget and provide more detail in our discussion. $72 million for mental health services, which will match $164 million in federal dollars. $28.4 million to maintain supported housing for 1,700 residents. $52.6 million for substance use disorder services. $18.3 million for crisis services. $50.4 million to support children, youth, and families. That includes $7.3 million for prevention and early intervention services, and $103 million to support St. Elizabeth's Hospital. I would now like to discuss Mayor Bowser's enhancements to the proposed budget. $24.5 million in behavioral health services to match Medicaid funding for increased utilization of services and the anticipated rate adjustment. $1.6 million to support residents with housing subsidies in partnership with the Department of Human Services. As the district government has succeeded in moving people from homelessness into their own homes, there are some residents whose behavior consistently is disruptive to the well-being of their neighbors and suggests that behavioral health supports are needed. I am deeply appreciative of the neighbors who have shown compassion and sought help for them. And I also recognize that it is unfair for them to live under such conditions. The community response team and frequently MPD respond often to daily calls for help, but involuntary treatment typically is not an option. Further, short-term emergency care is not the solution. The $1.7 million will support ongoing engagement and the provision of individualized support to assist them in living successfully within the community. The FY24 capital budget includes $9.5 million to open a second sobering and stabilization center to support individuals under the influence of alcohol or drugs who require stabilization services and support, but do not need to be transported to a hospital emergency department. The FY24 budget also includes $2.2 million in operating costs to support the first center expected to open this summer. The proposed budget includes $1.1 million to support the inflationary costs of medications and food at St. Elizabeth's Hospital. I take every opportunity to say publicly that I am extremely proud of the St. Elizabeth team who worked on site along with all of our first responders throughout the pandemic and to make sure and maintain care. The proposed FY24 budget continues support for children and families at home, in school, and as needed during crises. Children and young people have been particularly impacted by the pandemic as disruptions in routine and relationships have led to increased social isolation, anxiety, and learning loss. Studies show that use of social media also has created anxiety and depression as it presents a warped view of reality and challenges body image and self-esteem. The school-based behavioral health program was set up to make it easier for children and their families to get treatment where kids spend most of their day and where the eyes of many adults are on them. Cities around the country are making mental health supports available in public schools. Washington, D.C. is a national leader as the proposed FY24 budget of $37.6 million funds at least one licensed clinician in every public school through multi-year investments by Mayor Bowser and the council. I have attached a brief breakdown of the proposed FY24 budget to my testimony, which was submitted to the committee. The DBH clinician and CBO clinicians are a part of the school's behavioral health team that could include the school social worker, a lead teacher, a school nurse, and a parent, and is led by the school behavioral health coordinator. Behavioral health clinicians from DBH or contracted community-based organizations are now in 153 or 63% of public schools, and we continue to expand in partnership with DC Public Schools and DC Public Charter School Board. School-based clinicians are expected to provide prevention, early intervention, and treatment services funded with a combination of local dollars and billing through Medicaid and private insurance. To guarantee the delivery of prevention and early intervention services that are not eligible for Medicaid reimbursement, DBH provides $63,153 per clinician for salaries. The total budget support for CBOs is a little more than $23 million and includes $89,366 per clinicians for salary, personal development, and supervisory support. In our performance oversight hearing, we talked about the challenges of hiring and retaining nearly 300 licensed social workers. The proposed FY24 budget maintains funding to support our workforce development initiatives. In addition, DBH will participate in the new workforce development fund proposed in the mayor's budget to support our recruitment. We continue to work with our partners to examine the model to make sure that we are using our significant resources in the most effective way and are reaching the students and families who need support. I want to take this opportunity to address funding for Healthy Futures. The mayor's proposed budget maintains current funding to support Healthy Futures in 182 child development centers. There is no reduction. Healthy Futures funds inadvertently were placed in another program area. The total amount in the proposed budget is $4,124,412. The proposed FY24 budget also includes $28.2 million in federal funds to support evidence-based prevention, harm reduction, treatment, and recovery strategies in our Live Long DC plan to fight the opioid epidemic. Opioid overdose deaths driven by fentanyl continue to climb, though at a slower rate. The chief medical examiner reports the deadly synthetic opioid was in 96% of the overdose deaths. 448 of our neighbors died last year, most in their own homes or in the homes of family and friends. We are doubling down on the distribution of naloxone with a push to reach people facing opioid addiction and their families and friends. Last year, more than 2,600 overdoses were reversed. In the 4 years since we started our Live Long DC campaign, more than 130 government and community partners distributed 156,000 naloxone kits. Along with naloxone, we are distributing fentanyl test strips to check for the presence of fentanyl. Last year, we distributed more than 1,400 test strips. We are making more treatment options available, and last fiscal year, there was a small increase in the number of people in medication-assisted treatment. I want to end my testimony by recognizing the budget's continued support for consumer leadership and peer integration throughout our system of care. This year, we resumed in-person peer certification training. Peer specialists now work in the provider network with our treatment teams in community emergency hospital rooms, our emergency care facilities, and in St. Elizabeth's Hospital. Consumers conduct the annual consumer satisfaction survey. In addition, DBH funds 4 peer-operated centers. In conclusion, Mayor Bowser's proposed FY24 budget for DBH provides ongoing and new investments that support the opportunity for residents with behavioral health needs to live longer, healthier lives. Madam Chair, we appreciate our partnership and the work of the committee and look forward to our continued work together. I am ready with my team to answer any questions that you may have, and thank you.
Thank you, Director. For my colleagues, we'll start with 10-minute rounds. And go from there. Just 1 second. Okay. Director Bazran, let's start with some of the enhancements that are being proposed for the DBH budget. So first, you testified that there was a $24.5 million increase in FY24 for the Medicaid local match for behavioral health services. Mr. Adrian is here. We had this conversation yesterday with Department of Healthcare Finance in terms of wondering around how we got to the number. So how many services are we increasing the rates for? And what data or information did you all use to justify those increases? Was it utilization? Was it survey data?
Yeah. Thank you for the question. First of all, we worked very closely in partnership with our Medicaid agency in terms of this particular process. Historical utilization data and enrollment data was used to project expenditures. Provider capacity and service needs were also considered as one of the factors. And we also had an expanded menu of services. There are 13 new services that are now Medicaid eligible that were formerly paid for out of other funds, particularly local funds. Preliminary recommendations from our behavioral health rate study were also used and factored in. And we know that for Medicaid, that the Medicaid rate study will be concluded in the 4th quarter of FY23. So those were the factors that were used. I do want to say that our provider community was very heavily involved in this whole process because, for example, we had data from both small, medium, and large providers because we did want to make sure that whatever rate we were using really addressed the overhead cost of various types of providers. And we also wanted to get their view of what was needed.
Okay, so you're saying it was a very collaborative
Yes.
effort between you all and healthcare finance in terms of how you got to that number.
And also the provider community.
Okay, do you anticipate an increasing utilization as a result of these rates going up?
Well, yes, we are seeing increases in utilization over time. Particularly if you remember in our last, the last time we were together, telehealth we're seeing is increased. The other thing is as we, for example, bring on new services like wraparound supports, we know that that will also result in an increase in utilization of Medicaid eligible services along with the other services that now will be a part of the SPA.
Okay.
And I might add that one of the things that has been considered is a number of evidence-based practices, particularly looking at expanding kind of trauma-informed care, and those also are included.
Okay. In addition, I wanted to ask, so the mayor's proposed budget includes a $2.5 million enhancement, but it's at DCHR. But it says to establish a fund that will help the recruitment of hard to fill positions, including social workers and psychiatric nurses at St. Elizabeth's Hospital and the emergency care facility identified by DBH. Why was this money not placed in your budget? Why is it at DCHR?
Well, I think the reason it was not placed in my budget is because it is a citywide effort. Because we're finding that there are similar positions that are being recruited across the district. And so it is citywide.
Okay. Can you provide more details then on this fund in terms of, do you or the CEO for St. Elizabeth say, hey, this position should receive some sort of enhancement for this fund? Who signs off on who gets the plus up or not? And just from a process standpoint, who decides?
Well, from a process standpoint, what I'd like to say is DCHR will manage this particular fund. Agencies will have an opportunity to request funding, support, and then those determinations will be made citywide.
Okay, so you don't have, say, you don't know that, like, okay, for DBH related positions, you have $500,000.
No, we do not know that.
Okay.
We have to apply for the funding.
Okay. For the last 3 years, DBH has limited or paused provider certification for several service categories, including closing certifications for CBIs level 1, 2, 3, trauma-focused cognitive behavioral health, and others. Yesterday, we had, yesterday, there was a provider who testified at the healthcare finance hearing about the moratorium in place for mental health rehabilitation services. What is the reason for, well, let's talk about that one in particular so I can get those residents an answer. What is the reason for the mental health rehabilitation services moratorium?
Well,
it's been in effect for about 3 years now.
Yes, well, it depends. And one of the things I'd like to say is there isn't a full moratorium on all services related to behavioral health. Essentially, what we do is we look at, for example, are there wait lists in a certain area? And so we need more providers in that area. Do we have sufficient capacity across the system to provide specific services? So we do have applications open with this particular provider. If you want more details, I do have specifics on Metalworks that I can certainly provide to you. But we, for example, all of our information in terms of what if there's where there's a moratorium and where there isn't is in the DC register. For example, right now we are accepting all levels of substance use disorder treatment.
So I have that document, Dr. Bazran, but it doesn't provide information on a number of things. So first off, how long have these been closed? A lot of them say limited, or your staff community, oh, it's only a limited moratorium. I don't actually know what that means.
A limited moratorium means that all services are not under a moratorium. So for example, if you are a CBO, a community-based organization in our school-based behavioral health care services, and you choose to be certified as an MHRS provider, you have that opportunity because we want to make sure that our school-based behavioral health CBOs can actually provide those services. Okay. So that's an example. The other thing to think about is the services where we know that we have need, like clubhouse, for example. We only
Mhm.
have one clubhouse.
Right.
Like substance use disorders. We know we need more providers in that area, particularly around youth. That's open. But on the basic mental health, MHRS services, we do have, we have over 50 providers. We have a number of providers within our system.
So is the concern around oversaturating the market or?
Well, it's twofold. One, it's at that point, based upon the assessment, there isn't a need for that additional capacity. And also in terms of our ability to really manage just an open market where there could be, many hundreds of provider, it's limited.
Okay. I'll want to follow up with you offline on
Sure.
that one in particular. Okay. So in terms of, let's talk rate studies, because this came up a little bit yesterday as well
Mhm.
with healthcare finance. How many rate studies are you all currently engaged in right now?
Well, we are engaged in an overarching rate study that looks at all of the services that were in the 1115 waiver and many other services that are behavioral health related. We haven't had an increase in many of those services in quite a few years. And so they're really looking across the board at mental health related services. And so that's where we
Should we not be doing rate studies on things like this every year?
Well, the issue is that you do a rate study, and then what most places do is then they have some sort of adjustment, like a COLA adjustment that is an inflationary increase. And so to do a rate study every year probably is not the best strategy.
Mhm.
And so we are taking this opportunity to do the rate study now. We also, as you know, have a second rate study that we are involved in, and that is the one that is related to school-based behavioral health.
Right.
So there are two ongoing right
Two.
now.
Okay. I would say this, I think that obviously I'm not a rate studier, or I don't do that work from a consulting practice. But the one sort of stakeholder that's kind of missing in a rate study are all the providers that would be accepting Medicaid or would be willing to accept a Medicaid patient, but are choosing not to, in terms of trying to understand how much would it take for you to open up your practice to start taking Medicaid patients, or to allow Medicaid patients to have access to your services.
Right. And Mr. Neff can also speak to the wide range of providers that are involved, and outreach was really an essential piece of this.
Okay. I'm over my time.
Go
I'm kind of, so I'll come
Okay.
back to it. All right. I'm trying to be respectful. Councilmember Parker.
Thank you. Dr. Basran, I want to come back to the moratorium and the discussion you were having with Chair Henderson and the limited moratorium, as you put it. And essentially, you're speaking to an oversaturation of the market, or the capacity, as you put it, we don't need 100 providers. And so do you have a specific number, how many mental health providers there are in the district currently?
There are 76 providers overall within the Department of Behavioral Health. There are other providers through the FQHCs, as you know, and there are also people, private practitioners in the marketplace, and practice groups.
76 total, to my understanding, includes some providers that have since closed or moved on. At our height, what was the total of providers in the district?
I don't know what the height was, but around the 70.
Okay,
It's been
so
around there.
we're at a high point, you would argue.
That's correct. I would argue that.
Okay, and so we heard pretty compelling testimony yesterday of a native Washingtonian and that is wanting to provide services but cannot get into the district and is forced to serve and provide services in Maryland. And there's just ambiguity around why this moratorium is still in place. And so can you just more clearly articulate what is the concern? Because you would still need to certify providers. What is your concern if we were to lift the moratorium?
Well, first of all, here again, the moratorium is placed in areas where it needs to be placed. So If there isn't a wait list and it doesn't look like we need increased capacity in a particular area, then a moratorium is placed there. If we need additional providers, then we certainly open it up for others to join. Now, in the case that you talked about, specifically, here again, if the individual provider chooses to, there's an echo. Okay, chooses, my apology, it chooses to work in school-based behavioral health, which I think was the intent. If that person had moved through that process effectively, there would have been no barrier to really becoming an MHRS provider. Unfortunately, that didn't happen.
Okay. Thank you. I think that was a clear response than I believe anyone has gotten in a while. So I hear you loud and clear why you believe the moratorium needs to be in place and the steps one could take. I want to go to the school-based behavioral health program. The fiscal year 24 budget cuts grants to CBOs in that program. In your pre-response hearing responses, you make the case that the funding, including in last year's budget, included one-time grant funding from the ARPA funds at the amount of $28,000 and about $37. The question I have is, what analysis, if any, has the agency conducted to get a sense of what impact this will have on the school-based behavioral health program, the reduction in the grant amount?
Well, first of all, I'd like to spend a moment just to clarify
Okay.
what the resources are that are going to providers and what a survey of the provider community realized in terms of the salaries that they are currently paying clinicians, because I think you need to really we need to look at both pieces of that. And so in the FY24 budget, the salary is $63,153 per.
And let's go back and forth here. Yes. And
Yeah.
that is the same amount that it was in fiscal year 23.
Correct.
Yes.
And $1,000 in personal services. And then in addition to that, in FY24, we will be able to provide $8,546 in one-time workforce development funds that will also go. Now, the other thing that I think is really important for us to think about is that many of the staff will need to get, particularly those that are licensed graduates, will also need to have supervised hours of supervision. And we provide $16,666 per clinician for free supervisory hours so that they can meet that requirement. That can be very expensive if you're paying on an hourly basis to meet your 2-year requirement for supervision. And so I think we also need to kind of think about that as a part of this. However, the salary that goes directly to the clinicians in FY24 is $72,699. Now,
Can you give that number again? I'm sorry, 72,000.
$72,699. And so now I want to switch and talk a little bit about, I'm sorry, a little bit about where we are in terms of the salary range. If you look at the range of salaries that are currently being paid, there's some feedback.
Councilmember Parker, can you go on mute? Yeah, thanks.
Okay, thank you. If you look at the salary range, that we actually did a survey of all of our providers to get this information. And what we found is that the salary range, if you look at the lowest salary, is around $55,000 per year for a clinician. And the highest salary, and there are only a couple of the agencies that do that, is in the high 70s or 80,000. The average is around that $70,000 mark in terms of what is currently being paid to the clinicians.
That is helpful. And I have a question. How are you getting to the $72,699 figure? Because I'm seeing the salary base amount of 63,153, and I see the enhancements. Can you just explain how you're getting to that 72,699 figure?
It's 63,153 plus the 1,000. Okay, so that gets you up to the next amount, and then the 8,546.
Yes.
Is that right?
Okay. So I guess my
Okay.
my confusion here is we're looking at salary ranges in the chart that you provided below. And some of the figures that you're talking about, like for instance, professional development, that wouldn't be included, I wouldn't think, in someone's salary.
No,
And arguably, nor would workforce development at 63,153. That is well below many of the ranges that you have even here in your survey.
Well, I here again, as I said, the range, the beginning range, or the range for the salaries, I'm looking at a list now, is $60,000 per clinician. And that goes up to, as I said before, many are providing the top range in the 60s, and we have a couple that are providing it in the $71,000 range. And I'm happy to share that with you.
Yes, I think there's just going to need to be some work.
But the other thing too that I need to share with you is understanding that the 63,153. Let's just take that as the basis, okay? Remember, that is to support the non-billable aspect of the school-based behavioral health program. So that's for prevention and intervention services. In addition to that, and this is based upon the agreement that was made when the program was started with the provider community, we are supposed to, the Department of Behavioral Health, pay for 50% of the salary of the clinician. The remainder is to be billable funds that come through Medicaid, because we also need our young people to receive treatment services. That's one of the reasons why they are lodged in the school. And so this is not all of the funding that's available. And so you got the 63,153 base salary. Then you have what would come in through billing, if that helps you. And so, in my estimation, funding is not the issue.
And you would argue that the cut, you all are maintaining funding in many of the line items, but it's ARPA funds that are drying up, which is the reason for the cut.
Well, ARPA funds, which are the one-time workforce development funds, we do have some of those funds that will continue. The $8,546,000 amount from ARPA will continue. And then we also had some one-time local funds, and those will not continue during the next year.
Okay, that is my time. Thank you.
Thank you, Councilmember Parker. Director, I want to pick up a little bit on where Councilmember Parker was on the school-based mental health piece. And so this year local enhancement, the 19,000, that was what council added plus what this was the incentive, the retention incentive money that you all added last year, or for this current year.
I'm sorry. There's no cut in our budget for school-based behavioral health.
No. What I'm saying is, in this current fiscal year, FY23, there was a one-time enhancement of the $19,491 for local.
That's correct.
The proposed FY24 budget does not include that enhancement because it was one time.
That's right.
Okay, so that's how we're getting to.
Yeah, and so one of the things that we did in terms of this 19,491, that was really funded out of vacancy savings within the budget, but we don't
vacancy savings from DBH or vacancy savings out of the school-based mental health program,
school-based behavioral health
where there were
program.
vacancies of clinicians. Okay, So is it possible to presume that, considering there are still lots of schools who don't have clinicians, that there will be vacancy savings made available again in FY24?
Hopefully we'll be able to recruit, and I can't make that determination at this time.
We all hope that we
I
can
can't-
recruit, but I would be honest with you, Dr. Bazran, like when you, I guess these were in the peer hearing responses, the survey that you guys provided.
Mhm.
These seem low to me. Now, that is taking a part,
What
I
is
guess
that,
the-
Councilmember? The salaries?
the salary range seems low. And let me just explain why, because I think that the overall model that we have for school-based mental health, where we are desiring for these clinicians to be doing more of tier 3, is not happening. And so I think the larger question we should be asking ourselves is, should we be changing the entire model based on the reality of our CBOs never meeting that mark in terms of the number of students they are getting to commit to treatment?
Well, I think that there are a couple of things. First of all, council member, we are actually looking at the model along with the School-Based Behavioral Health Council. And we're looking at the model. We really believe in the model that we have right now that includes prevention, early intervention, and treatment. The public health model works. We do feel that our young people should be able to get treatment where they spend the majority of their day. And so the issue then becomes, do we need a licensed clinician to provide prevention services? Or could somebody else do it?
That's a
So
good
that then
question.
they have more of their time that they can then devote to treatment services. The other thing that we're looking at is, how do we look more closely at the specific types of services and the structure of the program that should be conducted at every school? What are the benchmarks that we are anticipating that everyone will meet as a part of our evaluation efforts?
Okay.
And so I think there are a lot of those sorts of things that we are looking at right now.
Okay, so it is April, school year's over in June. How many people don't have clinicians right now?
Well, as I said earlier, we have 92 vacancies.
Okay, so that is savings, yes? We're not spending that money on somebody's salary, correct?
We have 92 vacancies at this time.
Okay. At what point will you all decide to reprogram that in a different way?
Well, I think it depends on what our recruitment efforts look like. And our interim director of Child and Adolescent Services, Dr. Megan Sullivan, is also here with us today. And together we would look at that.
Okay.
Okay, and Dr. Sullivan?
No. I mean, that's okay. Let's ask some, let me ask just some other ones. Because I'm trying to get to I totally believe that I think in the perspective of students being able to receive treatment in the place where they spend the majority of the day, what you said, I think makes 100% sense. But then I'm trying to manage that with the parade of young people who come and testify before this committee saying, I want mental health services, but I don't even know who the clinician is in my building. They're only in the building 2 days a week, XYZ. So in our contracts or in our agreements that we have, are we looking at how we enhance in terms of putting that focus on how do you incorporate yourself into the school? How do you make the relationships to get to the tier 3? Because you can't just jump from 0 to 3 without someone having some relationship with you.
Correct. Well, first of all, I'd like to say that the school-based behavioral health clinician role is full-time. They are to be in the school 5 days a week during school hours, and and then as needed, work with families in the evenings after school. And so these are full-time positions. And here again, as a part of our monitoring activities, we will be ensuring that people are there full time. That's number one. The second thing is, yes, I worked in schools for many, many years, and there are various ways of meeting with families and engaging with families so that when their child needs to have additional services and supports, they will agree to it. Because the parent does need to give permission for treatment services to occur. So that happens, as young people are coming into the school building in the mornings. It happens when they're leaving. It happens at PTA meetings and other school activities
So
and so
if the
forth.
consent part is part of this, is that what is making it more difficult on the high school level? Because
Yes.
I mean, the majority of the students who come to testify are high school students saying, we need help.
Correct.
But a parent is not dropping off an 11th grader.
That's correct.
So how do we get to that
So
part?
that's why a part of the program is outreach. So that they need to contact the parent, if they need to meet with the parent at home or some other place to explain the program, then there is the ability to do that.
And what if the parent is the impediment?
Pardon me?
The student needs it, but the parent is saying no.
Well, in accordance with our regulations, parent permission is required.
Okay. For the past few years, Child Trends has been evaluating various aspects of the school-based behavioral health program. Do we have any preliminary findings on their work thus far? I believe they have 2 contracts totaling about 500,000.
Yeah, Megan, you want to come on? Yes, as a matter of fact, we do. And so I'm going to have Dr. Sullivan respond to that.
You can just introduce yourself for the record.
Sure. Good morning.
Oh,
Megan
turn your mic
Sullivan.
on.
Good morning, Megan Sullivan, Interim Director for Children and Youth Services. And so, yes, we have some preliminary data. In fact, just I think last week or the week before, Child Trends and DBH presented at the Coordinating Council. And so we have, beginning in September of this year, we've been collecting data. We've created a new database. And so all of our clinicians are entering daily activities. And so we're starting to get, a picture of school activities as well as activities on tier 1 or prevention, as well as early intervention and treatment services. In addition to that, while we continue to, again, it's a relatively new database, and so it takes time to shift. So we're gathering that information and then trying to, as Dr. Bazaran mentioned, we're also adding benchmarks and really putting some structure in place so that clinicians as well as supervisors know what that looks like.
Okay. George Washington University leads the community of practice, and in the proposed budget includes a 593,000 and some change grant for training and report development. Is that an agreement for them to continue to lead the community of work, community of practice work?
Yes.
Okay. Is the grant competitive, or is it just we're doing a continuation with GW?
It's a continuation at this point, but originally it was competitive.
Okay. Do you have any updates on the rate study?
Well, and I want to really step back a moment and talk about some of the reasons it's taking us a little longer. One of the reasons is that we needed to make sure that we had data from our providers.
You just speak up a little bit more.
Oh,
So
okay,
yeah,
sorry.
lean into that.
We needed to make sure that we had data from all of our providers because certainly we wanted to make sure that the information was accurate and representative of what was happening in the field. And it took us a long time to really get a good response rate from providers. And still to date, we have 2 providers who have not submitted that information. So
that, I mean, that was that a 98% response rate? That's not bad.
well,
Ish.
it took work to get there, is what I'm saying. And so work takes time. And so I just want to share that that's a piece of it.
So what's the updated timeline?
Yeah, there's an updated timeline. The study is currently in progress now that they have the data. And we do anticipate that we should have something probably within the next month or so.
Within the next month.
Mhm.
Okay. May is going to be a big month for the Committee on Health.
That's
'cause
right.
We are waiting on lots of other reports that are also supposed to be coming out in May. I'm over my time. Councilmember Parker?
I want to pick up there. So assuming we get that report and analysis in May, then what happens?
And then in May, we'll look and see what the data shows in terms of the need. And then we will have to sort out if it's extremely high. At this point, we're not anticipating that, but if it is, then we will have to figure out how to fund the increase in FY24.
And potentially that could come by way of those 90 or so vacancies, right?
Here again, we'd have to determine what strategy we would use.
Okay. On the school-based behavioral health, did we ever get an accurate number or an accounting of how many schools? Let me ask, how many schools don't have clinicians?
92,
92 do not have them.
yes.
Okay. And I wanted to come back. Has there been around the proposed grant amount funding, the impact that that would have on the programs and the schools that do have clinicians?
What did you say? I'm sorry.
So in the last round of questioning,
Right.
I asked, like, what analysis, if any, has the agency done to assess the impact of the proposed grant funding on CBOs and providers in schools through the school-based behavioral health program?
Well, quite frankly, what we have received to date is the salary range in that survey from the clinicians. And from my perspective, we are not going to be cutting the basic salary that we offered when compared to FY23.
And how many CBOs are part of the school-based behavioral health program?
13.
13. So this represents all of them.
13.
Got it. Okay. Well, I don't want to get too far ahead of Chair Henderson, but I believe this is really important. I believe she thinks this is really important. And I'll speak for myself. I look forward to working with you to just make sure we can maximize every opportunity to really advance this program, because I have concerns that the budget as allotted will not advance the program and in fact may set it back. And I believe it has a lot of promise. So more to come on that.
Right. And council member, I did want to clarify that we did get 2 additional CBOs recently. And so there are 15.
There are 15.
Yeah.
Okay. I want to come to substance abuse. So there is roughly $3.2 million to cover the sobering centers. And one question is, does that include both sobering centers, the current and the proposed center?
There's an additional 9.5 million in capital for the second center. And,
Okay.
and the 2 million is actually for operating costs for the center that's to come online later this summer.
And together, that's the 3.2 million, the operational cost for the 2 centers. In your that's not right. Okay. In the pre-hearing responses, it seemed like you were suggesting there's $3.2 million committed to this. I want to move on just for the sake of time. We've heard a lot of concern from those that are interested in a harm reduction center. Would love to get your perspective on that. But there were 3 things that were elevated from those that testified. One was the provider that was selected for the sobering center. 2 was the location of the sobering centers. And then 3 was the need, or why are we moving in this direction versus in some other direction? I know that was a lot. So if you could just quickly speak to those 3 things.
I'll quickly do that. First of all, the provider was selected as a part of a competitive bid process. We had to put that RFP out several times, and we got CBI as the provider. They have operated and are currently operating 23 other centers that are in the state of Arizona. So that's that one.
And in that competitive bid process, were there any local providers?
Yes.
Because the concern was, why are we outsourcing these services when we have providers locally?
Well, I don't think we're outsourcing it away from providers. It was a competitive bid process. And so
I know how the general procurement system works. I'm not clear if you all have a say in that process, in the competitive bid. Is it different for DBH?
No, it's not different.
Okay. Let's go on for location.
It's not different. Okay, in terms of location, one of the things I can say about location is that based upon the heat map data that FEMS provides, the location of both centers really are centers where there were high numbers of overdose calls from FEMS, and so it appears that those locations are appropriate.
I mean, I would just say anecdotally, as the Ward 5 representative, I too had a raised eyebrow, not to say that there isn't a need across the city, but we know that the highest deaths and usually the worst marks across any metric are usually wards 5, 7, and 8. And so it was curious that these 2 centers are not being proposed in those areas. And then thirdly, I just want to come to the need for sobering centers versus harm reduction centers. Can you speak to your perspective on the value, and I don't want to say, because I believe there is room for both, but specifically for harm reduction centers, what is your perspective and or the vision of the agency as it relates to?
First of all, I think that we have to come to agreement on what harm reduction means. And a sobering and stabilization center is a harm reduction support and activity.
Yes, and I'm just jumping back and forth. I know I'm jumping in, but
now
part of the testimony we heard was a key difference, though, is that sobering centers are trying to get those there to abstain from engaging in substance abuse or drugs, if you will, whereas a harm reduction center is providing more of a safe space for people to navigate life on their own terms. So that was one of the big sticking points for those that testified.
Well, I can say that a sobering center, and by the way, there's data to show that they are very successful in doing a couple of things. One, helping to get people into care. As you know, it is a change process to go into recovery. And this is a place where you can go, you can sober, you can get information, you can have a peer attached to you who can talk to you. And our goal really is to help people as they move into recovery. So that's one thing. The other centers that you're talking about, I believe, and you're calling harm reduction, are also known as safe injection sites, is what I'm hearing. And here again, I think that we have to do additional research to find out the pros and cons of those. And I don't have enough information at this point to really have an opinion.
So what I'm hearing you say is the door isn't necessarily closed from the agency on that, but that there needs to be more study done by the agency on their value. Got it. In my remaining minute, I'm going to go to the MCO transition. A few things. I will just center on RAP here in Ward 5. They've talked about both the lagging rates for their services in particular, I was kind of shocked to hear that for residential-based programs, which I guess they would classify as, there hasn't been any supplemental enhancements even during the pandemic. Is there a reason why?
Well, actually, that's not.
Or is
right.
that accurate? I should ask.
No, that's not accurate. As a matter of fact, we work with Medicaid, and our residential substance providers did get significant funding and support, and that included RAP, by the way.
Okay. And then one other thing that was a sticking point was the data management moving forward towards the, I believe, October 1st deadline, and the agency's unwillingness to carry over data wicks in particular. In my last 5 seconds, you want to speak to that?
Okay, first of all, I have rarely heard anyone who had a positive thought about data wicks. That's
Yes.
number one. Okay, and number two is the department also provided grant funding as well as significant technical support to help providers move into the new system. And we've been doing that for quite a while at this point.
So what I'm hearing you say, there is no willingness to delay the
No,
sunset of that program.
no,
Got it.
there is no
Thank you.
willingness to do that.
Thank you. That is my time.
Thank you, Councilmember Parker. Dr. Bowser, we're just going to tag team because I think it's good for us to just have a fulsome conversation about some of these things. So going back to the stabilization and sobering centers, the first one is supposed to open up in June. Do you all have what I'll call rules of engagement in terms of who is eligible for the stabilization and sobering center? For instance, can I walk in?
Yes. You can walk in, and those who are eligible, FEMS will make sure that they're medically stable, because we don't want people who really do need to be in an emergency room there. And if you are medically stable, then you will be able to go into the center.
Okay, so who is so Community Bridges is operating, and I'm sure they'll have some amount of staff. FEMS's role in this is around drop off in those scenarios and incidents. But I'm assuming, so for Community Bridges, they will have staff. If somebody walks in, that they can do an evaluation and
They're gonna do it,
determine
yes, exactly.
whether or not this is the right setting or whether or not you need to go
Correct.
to a hospital.
That's
Okay.
correct.
I understand that you said you use the heat map data, but I think for some of us, it's a question of, okay, Noma kind of makes sense, maybe sort of. Columbia Heights, okay, I can also rationalize and make that sense as well. But I think earlier this week, wasn't there an overdose spike report of 24 overdoses in 24 hours? And when I look at the map, those aren't happening over here. Now, I guess that's a little bit different in terms of stabilization and sobering. Is that for both alcohol and for drug?
Yes,
Okay.
it's for both.
So are we thinking that at some point in the future, we will do a third something east of the river?
Hopefully,
Okay.
yes.
I mean, I think I also wonder too, in terms of picking this second site in Columbia Heights, what, if any, community engagement was done? Because when I think about the location, yes, it's near a metro, but it is also near a lot of other things that are going on in community, and immediately next door to townhomes, residential. So I don't want anyone to say that they didn't know, they were surprised, didn't have an opportunity to engage. Like, I know that it's a district-owned property, but to what level are we doing some public engagement to ensure that the neighbors are not gonna revolt?
Well, it's interesting because when we first started talking about a stabilization and sobering center, we really did receive a lot of requests from people who live in that particular ward to have it there as opposed to someplace else.
Interesting.
And so that's just step one. We still need to do the continued engagement and education and outreach to the community.
Okay. Are you, in sort of speaking of stabilization, sobering, and then also I'm going to get to substance use disorders, are you at all engaged in the conversations with the ANCs over in Anacostia around the challenges that they've been facing with the methadone clinic on Good Hope Road?
Absolutely.
Okay, and are you engaging in those conversations around the potential move of that clinic?
Well, as you know, one of the things that is currently being considered by UMC, by the hospital, is whether or not that would be a potential place and location. Deputy Mayor Turnage has been really spearheading that particular piece of the effort. And I guess their board of directors also is considering that.
Okay. I just, I don't want us to get to a place where we're just quote unquote passing off the community quote unquote lemons around the city in terms of, oh, it's an issue for one community, so we're going to move it to another place.
Mhm.
Where UMC has its own challenges, but also from a location standpoint, I want to make sure that people can still get the services that they need. UMC is not the most accessible place to get to if you don't have a vehicle. And so I just want to make sure that we're kind of keeping that in mind, but also that there's a conversation with the agency, your agency, not just UMC,
Yes.
around what we do there.
Yes, actually, our staff, Dr. Sharon Hunt, who is the person who is heading up our SOAR project, is out there literally weekly, meeting with the staff, seeing what we might put in place to alleviate some of the problems. We've done things like ensured that there was more security around the property. And we're really engaged and engaging with community leaders, including business leaders, to see, how we might together come up with a solution.
Okay. Are we doing that similar level of engagement? I don't see Councilmember Nadeau here, but I have received similar emails and calls around the 7th and T Street corridor by the Wells Fargo near Howard Theater around what is happening there. Is DBH sending outreach workers to that area?
Yes.
And I know you can't require people to go into treatment,
Right.
but what I don't want to see is businesses choose to not engage in outdoor space, not do things, decide to move because we as a government aren't doing anything for that particular area.
Yes, our outreach teams are out there frequently, providing supports. We respond to any calls that we get from members of the community. So we are out there.
Right. And I say it's not just a DBH issue. Unfortunately, in some of these instances, MPD is part of the issue too, because there are transactions that are taking place illegally. But sticking on substance use disorder, I want to talk about youth for a minute. My understanding is that you all are getting ready to release an RFA for a new community-based level 3.5 substance use disorder treatment facility. What's the budget for that? Or I guess estimated budget that you all have set aside for that in FY24?
Just give me a moment. I'll get it.
Okay.
for you. You have it, Michael? Okay, we'll get that for you momentarily.
Okay. A similar question on that is, do we
Yeah,
have
I
a
think
local?
it's a little over 700,000, but I'll get the specifics for you.
Okay. Do we have an anticipation or anticipated location for that facility?
No, we're actually, it is solicitation. So the person who submits the grant application.
Oh, we're wanting them to come with the whole,
Mhm.
come with your own facility and run it as well. Okay. How many substance use facilities do we have in the district that can take youth?
At this point, I don't think we have any that can take youth residentially.
We do not have
None.
any at a 3.5 level.
None.
Okay. What is the specifics of a 3.5 level? What are we talking about here?
Residential services for young people who want to move into recovery, and they have support to do that. But they're not detoxing at that.
No, I know. So this is a treatment type
Yes,
deal.
it's a treatment site.
Okay. Is 700,000 enough? we have no one
Mhm.
and we need somebody to come with their own facility and hopefully a minimum number of beds, right?
Mhm.
If you are just bringing one bed, that's not good for us.
Well, that's true.
So, I mean, I don't know, do we come back to the drawing board if we get no one?
If we get no one, then we often will reissue the solicitation based upon the feedback that we've gotten from potential providers as well as providers. So we're putting it out there. We'll see what we get,
Okay,
and then we'll move from there.
all right. How in this budget how does this budget sort of enable the DC prevention centers to improve their visibility and therefore increase access to programs and services?
Well, we continue to fund the DC prevention centers, and we fund them with a combination of local dollars as well as block grant dollars. And those particular resources help them in terms of the prevention and education activities that they conduct and the youth leadership and development activities. They also do things like they do naloxone education, they do community engagement.
In your opinion, are they working from a numbers
Oh,
standpoint?
yeah, I think that they are working, yes.
Okay. Don't have enough time to get off another question, and I see Councilmember Nadeau. Councilmember Nadeau, we're on 10-minute rounds.
Thank you, Madam Chair. I'm back. Director,
Hi.
always good to see you. Hi. And I'll say, I come here with some very specific questions, but I want to start by acknowledging that I think we should all be very proud of the depth and breadth of programs offered by DBH, and thank you for your leadership. I want to talk about, Councilmember Henderson started getting into it, substance use disorder and the one-on-one engagement that the CRT and other supports do. Because, you know, I think we still have some gaps there despite the great teams that we have out there. So how many people work at the CRT? How many people are out on the street?
In terms of our crisis services and the staffing, right now, as I think you know, for the CRT, we have 44 staff that have been hired. We are moving towards a 67 staff team.
And they work 24 hours a day, right?
They do.
So how many people do you have on at a time?
You want to talk about the model?
Good afternoon. I'm Richard Bebout. I want to assure the chair that in the car on my way over here, I raised my right hand and said I do to the swearing in, and I didn't miss a word of your testimony. It's variable. It can be as few as 5 on a shift to midday, Tuesday, Wednesdays, and Thursdays, where we are heavier and also have heavier activity. It can be 12 on a shift. We are working to reorganize that so that there's better spread across all 3 shifts across 7 days.
And do they work in all 8 wards?
They do.
And so that's a lot of territory to cover for even 12 people at a time, right?
Yes.
So, and I've talked to the director about this too, and probably you also, Mr. Bebo, Dr. Bebo?
Dr. Bebo.
Thank you.
Dr. Bebo. Because in Ward 1, we have a lot of high foot traffic areas, and we're a densely populated area, so we have a lot of needs for every city service. And I typically try to get on an annual basis, sort of like, how many touches have you done, et cetera. But I am not sure what that really tells us or what it's getting us, because what I worry about is with the teams spread the way they are and not necessarily being place-based, that they're not making deep enough connections with folks to help them make the change in their life or help them believe that accessing services is going to work for them. How do you see the staffing model as being effective or ineffective? I mean, what are the challenges?
So let me address that in two ways. One is that we, as you know, are working very hard to recruit. I'm looking forward to seeing what this looks like when we are at the strength that the city, the mayor, and the council have invested in. And we will get there. But the other thing that I want to say about this is just to remind all of us that the real goal of crisis services is prevention and intervening earlier upstream, which has to do with strengthening as you know, the vast majority of those services are provided by DBH certified organizations. And strengthening their ability to do crisis planning and prevention work so that crises are more readily resolved, they're effectively resolved, and are unlikely to recur. So we are also investing in intensive care coordination so that when we are identifying through data matches and so forth, we're identifying people that are frequently being seen by CRT or at CPEP, or where there are locations or individuals that are frequently being generating calls to police, that we are doing increased work to more securely connect them to ongoing care. So again, I think as we continue to strengthen the community-based services and as we move to the level that frankly we've generously been funded at for CRT, I think that we will see a very big difference. We are looking, I just wanted to say one more thing about the geographic distribution. We are actively looking at strategies for people being based at outposts so that they do have more regular access to hotspots, although as you know, we do a tremendous amount of hotspot outreach. We are part of the Minnesota Benning Road Task Force. We're part of the 7th and T Task Force. But reduced response times and more frequent non-crisis touches are critical.
And I really appreciate that. And thank you for speaking to the need for the intensive care coordination. And you know very, very well that some of the community-based entities that used to provide more of these services have, closed up over the years, in Ward 1, Neighbors Consejo, Andromeda, so we certainly we have a lot of gaps to fill in the government when that happens. And so I thank your team, and your team has also been very supportive of the pilot that I launched in Columbia Heights with District Bridges. So thank you for that. I think the sobering center coming there is going to be really important to that work, but the partnership that we've had with DBH through that grant has been essential as well. And we've learned a lot from it. I mean, since we put the boots on the ground in Columbia Heights with that grant, which was through DSLBD, so I know y'all don't have much of a touch on it, but they've got case notes on more than 170 individuals, and they've helped dozens of people. Last count I had was 38 people get into detox and rehab. And I think it's because, Sarah and now her counterpart are there every day, and they know them and they have learned to trust them. And so getting that level of coverage in targeted spots, I think, can be huge. And it doesn't necessarily all have to be DBH, right? We have trusted community partners. So the grant that I had asked for from the mayor in this budget was for the T Street Task Force that you mentioned that you're involved with. And we were hoping to do a grant that HIPS could compete for to do that type of work there. And so now Councilmember Pinto and I are trying to find that funding, obviously. Of course, we'll ask Councilmember Henderson for it first, but just seeing how it works. And yet I know that a ward council member creating ad hoc grants that have to then plug into your continuum of care is not the answer, right? It is something we're seeing as effective, but we can't keep doing it, on an island. So I'd love to know if you have any thoughts on how we might incorporate what we're doing in Columbia Heights to make it, I mean, we need to take it off pilot status at some point and you know, make it permanent or figure out another way to manage it. And if we're thinking about that this budget season and how it fits into your plans, I'd love to hear any suggestions you have so that we can mesh it into the continuum.
Thank you. As you know, I've seen you on Civic Plaza in Columbia Heights, and we have worked very well with District Bridges. I frankly have not seen the numbers and the data to be able to comment intelligently about sort of how to leverage that to build to scale. I do agree with you anecdotally that there's been a tremendous amount of impact and lives have been likely saved because of that. But I really would like to look at it. And I appreciate what you said in terms of, yes, let's learn from the pilot, but not just continue to do pop-ups. But how does that fit into the overall strategy, I think is exactly the right question.
Great. And you know, I mean, you see me doing this, it's more of a sense of desperation for my constituents who are suffering, right? There's other aspects to it as well. The economic development side of things are small businesses that are suffering, but you know, we're all on the same team here on that. So let me follow up with you to talk about how we can stand that up more permanently so that it's not just a continued earmark. And then it's in the right place rather than a DSLBD so that it can be better incorporated into your work. This is the end of my round, so I will stop there. Thank you.
Thank you, Councilmember Nadeau. Dr. Beebe, don't go anywhere. I want to ask who leads the 7th and T task force? Like which agency is leading that work?
I can, Councilmember Nadeau, her hand is raised.
Councilmember Nadeau?
It comes out of your office and it's.
No, it's Director Salah Shapari from the Office of Nightlife.
Oh, okay. Let's work more on that, Councilmember Nadeau. I think we've gotten a lot of, not just from the businesses over there, but also the families, because it's a block from a school. There's just a lot going on. The university is down the street. So I think that whatever we can do to increase outreach. I know that some people say their number one reason is that they don't necessarily trust the government or they don't trust those options, but how can we build trust if we're not there? Just to follow up, Councilmember Lewis George couldn't be here at the hearing today, but she did submit some questions that she wanted me to ask specifically on this. And so just to clarify, in terms of the CRT teams, are they broken up into regions? Are you saying no? Or what's that, your response on that?
We are currently operating out of 2 locations, and they do have essentially a sort of a geographic a split of the city. What I know, Councilmember Lewis George.
Okay, yes, she
Underneath
said
that, the question is about
but they're
workplace.
north and south teams, or are they organized by ward?
No and no.
Okay. All right, and then she says, how many vacancies do you currently have in the community response team?
We're moving from 44 to 67, so 23 vacancies
Right.
today.
So in terms of those 23 vacancies, are those ones you can act on in FY23, or are those proposed for
Those are
FY23?
ones that we're working very
Yeah.
hard to recruit for today.
Okay. And she said, advocates have suggested adding the 988 access helpline number to district issued documents like student ID cards or the DC-1 card. Potentially could be added to smart trips or Medicaid cards or something to that effect. Is this something that DBH would be open and willing to collaborate with other agencies on?
I think absolutely. We want to get the information out as broadly as possible. And that service is in place so that people who are in need of crisis support or suicide support can get services quickly. So you may have seen the posters that now have been posted around the city
Right.
on they're different on the bridge, they're in different places. And so as many ways as we can get it out, the better.
Okay. And how many individuals in FY 22 and FY 23 to date have called the mental health hotline to talk to a specialist?
I can get you the data. As Dr. Bazran reported in her testimony, we have seen an increase since 988 went live. We do have very good data. We actually have switched platforms, and so we're doing a lot of work right now to reconcile our reporting. If I may just add back to the earlier question about publicizing 988, it is something we're very eager to do.
Okay.
We have worked with DDOT to put signage up at some suicide-prone bridges, and are actively engaging in looking at other strategies with the transportation agencies. One of the reasons we have not launched a comprehensive public information campaign about 988 is that nationally, the FCC is still making a decision about changing the routing. The calls are currently routed based on the area code of the caller's phone.
Oh,
They're not geo
That's
routed
right.
like 911 and 311 calls.
so if you have a New York number of 917,
It goes to New York.
it
Correct.
goes to New, oh, I
Correct.
see.
Correct. And that it's a network of centers. They will manage the acute sort of evaluation and so forth. But because really the goal is to get you connected to the right local resources,
Correct.
we have sort of slow walked this until and in the hope that there would soon be a change in how the routing happens so that we could be more full-throated about promoting this.
Okay, that makes 100% sense. And my New York-based family is gonna be like, you picked 917, not 718 or 212. So let me just say that for the record. That I'm picking the right area code and I remember what the area codes are. Okay. So in that regard, around how we get this information out, although not a comprehensive campaign, obviously we heard lots of testimony last week from some young folk who were saying we need some type of youth peer-to-peer program in the same vein that we launched around sexual health within DC Health back in the day, which some folks say helped a lot in terms of bringing STD numbers down in the district, as well as teenage pregnancy rates. I see in the budget, you have $134,000 for youth peer recovery coaches. What will these peer coaches do and where will they work?
A number of them will work in the prevention centers.
Okay.
And they will do outreach, engagement, and education to their colleagues. They may also, the youth peers are really a tremendous group. I've had the opportunity to speak with some of them, and they're very knowledgeable and very well trained. And they can go into schools and talk to their school colleagues and so forth. And really that peer-to-peer relationship makes a big difference.
So how many of them do we have?
How many peers?
Yeah, how many?
I don't know how many peers we have.
Oh, okay. I'm just trying to understand how many people does the 134 get us?
Yeah, I can get you the information. I don't know how many people.
Okay, okay. And who is eligible for that program? Would a young person just apply to the
Well, if it's
prevention center?
if it's done through the prevention center, then they would do the recruitment.
Okay. Okay. But what about more of a school-based program? Would you be open to that?
Certainly open to it, yes.
Okay. They just were saying that for them, and I'm sure you and your team sort of review that testimony. They would say for them, they are more likely to ask their peer for help in some cases before they go to an adult that they haven't met before. And maybe as we're sort of thinking about what our system looks like on school-based behavioral health, it is incorporating the peers who can then say, hey, I really think you need to go talk to Dr. Bazran
Mhm.
in the
Mhm.
clinic's office, because I think she could really help you and provide some options for you, et cetera. Like that type of validation might actually work to get more young people to sign up for tier 3 with the CBOs. Now, we're going to come back to this parental consent piece, because I feel like that's a sticking point for some high school students, especially if many of their challenges and concerns are around their parents. Getting then your parent to sign off on your treatment that's dealing with the fact that the parents are some of the cause of some of the trauma, I think is something
I
we should.
think Dr. Sullivan can speak to this, but my understanding is that that's not totally the barrier, particularly for those older kids.
Okay.
Right. And so within DC, for some of the older kids, they are able to consent.
Right.
The challenge is that they have to be able to understand what they're consenting to.
Right.
So again, as a clinician, you have to make sure that you're getting their consent to participate. So again, there are opportunities. Best practice is always to include a parent, right, and family within treatment. There are some circumstances where the parent could be part of the struggle or part of the goals. And so within our treatment, we obviously try to follow the best practice. But if a youth is coming in for treatment, they can consent for treatment as long as they're able and understand what they're consenting to.
Okay.
I just wanted to go back to the peers as well. I
Yeah.
think that I don't want to speak too much on this, but DCPS also has like a peer ambassador program. And so they are using youth to help engage. And so I think that is powerful. I think especially with the older adolescents, right? Peer-to-peer.
I think the chancellor is before, not my committee, but another committee tomorrow. I'll ask you about this. I'm really just trying to reconcile with, and this is not with just this, but many things across DC government where I'll go to neighborhoods and they say, we don't have access to this. We don't have blah, blah, blah for that. We don't have the XYZ for that. And I'll say, well, we put money in the budget for X and Y and Z, and we have this program and this program and that program, and this is going on and da, 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 da. And like they'll say, well, we have no idea. And so there's some sort of disconnect that's happening. Now, mind you, there are people who, unless you deliver it to their house on a platter, they will always say they didn't know. And even then they'll say, oh, you put it in my mailbox and not through my door, right? So we kind of have to deal with that. I'm just wondering how we can sort of address, I think, the very real concerns that some of the young people are raising. But I'm over my time. Councilmember Nadeau, and I also just note that we've been joined by Councilmember Gray. Councilmember Nadeau will do her 10-minute round, and then we'll turn to you.
Thank you so much. So I know my colleagues talked a little bit already about the Sobering Center coming to Columbia Heights, and I wanted to ask a few specific questions. I know the chosen location, the old firehouse on Park Road, is in bad shape and will need a lot of remediation. I think some folks were surprised at the $9 million price tag, but I understand that's likely needed given its condition. First of all, is that sufficient funding to complete the project?
The capital piece of it, yes.
Will that be the full build out, or is that just a warm lit shell? What will we get for $9 million?
It will be a full build out. So currently we've completed the engineering assessment and worked with architects, and that's DBH working with DGS and the architects to do fit testing to make sure that the space is appropriate for the needs of the program. And then this will now kick off a whole new process as there'll be a solicitation. The manner of the solicitation is to be determined. We're talking through that right now, but we meet weekly with EOM and DGS and DBH to, really fast track the process as best we can.
What's the timeline for that solicitation?
We don't, our timeline is due in a couple of weeks now that we have the assessment completed. So we're DBH and DGS is working together currently on that.
Do you have any concerns about the fit testing?
No, we are very pleased with the results.
Okay, very good. Now, I know Councilmember Parker started to dig into this, but I want to confirm how much operating funding is budgeted to run the Park Road Center once it's built?
We do not currently have an operating budget. We'll be looking at the timeline for when the second center is ready. And at that point, we will need to either submit a supplemental funding request or include it in our FY24 enhancement.
You do hope to have it online during FY24?
We don't know that yet.
Do you expect to operate it yourself or to have a contractor?
No, we anticipate having a contractor operate the center as opposed to government operating the center.
How many people do you expect it to be able to serve?
It depends. I mean, I think some of the data that we have from other centers around the country, there've been as many as 1,200 people that come through the center in a year or upwards to that. It depends on the geographic location and need.
Well, you'll know a bit what the capacity is from the work you're doing right now. Have you gotten to
Correct.
that yet?
No, we haven't gotten to that yet. We have not gotten to the program development piece of this yet. We certainly would be working in tandem with all of our partners around that. But at this point, we're trying to get the building in condition. And as you know, it's an older building. There are lots of issues that will take remediation for a longer period of time, which is why we're starting now.
Thank you. I appreciate that. May I request that you have a community-based advisory committee guiding the program?
Okay, thank you for your recommendation.
Okay, I would definitely like to be involved, and I think there's some other nonprofits doing work in the area that would be great to just help when you're thinking through the program about who we've been serving in addition to the DBH programs. Can you talk about what, and Dr. Bebo talked about this a little bit, but down on T Street, where the T Street Task Force is, what is the service level there right now, and what is the plan in FY24 for service level there?
Well, I think here again, we respond to whatever the needs are within that community. And the CRT is then deployed to do that. In addition to that, our outreach teams are also out there. And so I don't know that I can say it's going to be X amount of time, on these days of the week or what have you at this point.
Sure, but given it's a real world example, how often are we deploying resources there now?
Sharon? I'm going to have Dr. Hunt come up to talk about that because she actually is deploying outreach workers there.
Thank you.
Good afternoon. Hi, I'm Sharon Hunt, State for Treatment Authority for the district and work with DBH.
I'm sorry, Dr. Hunt, I don't think your microphone's on.
There you are.
Here
There you go. See, it happens in real life too, not just on Zoom. You're muted. Okay, go ahead.
Yeah, so we actually have a tracker of when our syringe service teams go out, and you're familiar with some of them, HIPS, Family Medical, Us Helping Us. And I was just looking at the tracker, and we have teams out all three of them go out multiple times a week. HIPS was out on Monday. Us Helping Us went out Tuesday morning to do a cleanup. I assume that they found syringes and things. So it's multiple times a week, maybe almost daily. All three teams hit it. And actually on Monday, we had a Ward 1 meeting, and that really focused on, and these meetings are focused around the opioid issues specifically. And the 7th and T location was a focus of that meeting, and really doing what you said about intensive outreach, consistent outreach, which our teams do, but really talking about who would be the lead on that and things like that. So it is on our radar, and we're working on a plan around that, around the opioid specific piece.
That's really great to hear. And I know, as we discussed earlier, there is this task force that's going, and there was some multi-agency intervention, but it's not really gotten much traction, to be completely honest. And it is my impression that of the multitude of things going on in that area, the substance use disorder and the need to serve those experiencing that is the most acute and pervasive element of the challenges there. And so, MPD doesn't really have a role. There's a couple other things that DDOT can be doing, DPW, but it really is, I think, a DBH response. And certainly we've worked closely with your team and with HIPS, and maybe less so with us helping us, although, we certainly know them and as a Ward 1 based provider. Given that, it sounds like the meeting that you are holding is pretty powerful. Is it possible that my constituent services team could be a part of that conversation?
Absolutely. Mhm.
That would be great. I think we really are trying to support the executive on their coordination here, but I think we're just missing a couple things here, and maybe if we get some of your people in the conversation.
On our Ward 6 meeting and Ward 5 meetings, we have constituent services join those.
Oh,
meetings.
great.
So, yeah, happy to have.
I'd love it. That would be so great. All right, so we're going to follow up with you almost immediately, so that we can make sure that we are sharing information and that we are supporting any way we can. But I'm still going to be, as I mentioned to Dr. Bazran and Dr. Bebo, looking for funding in FY24 to try to enhance what HIPS is doing there so we can get that consistent coverage. But it is really good to hear that you think between the two organizations that we're nearly there daily. I think what I'd really love is just to make sure it's like the same person, that those relationships are being built. And I know alcoholism and other drug use is not the same, right? You can't just pull something off a shelf and say this is going to work here because it worked somewhere else. But certainly that human contact we know helps. So thank you. That is all I have, Madam Chair. I thank the team very much.
Thank you, Councilmember Nadeau. Councilmember Gray?
I'm sorry, Chairperson Henderson. Would you give us a moment, please?
Sure.
Thank you. Thank you. You're on mute.
Councilmember Gray, we're getting a lot of feedback, and that you think it's the speaker that you guys have on your.
Councilmember Henderson.
I'm good. Can you hear me?
Yeah, I can. Yeah.
Okay. Is it possible that you guys can turn down your speaker on your side?
Yes. We're doing the best we can to try to get the feedback eliminated.
There it is, all eliminated. Go ahead, Mr. Chair, or Councilmember Gray.
Okay.
You still getting it?
A little bit, but turning the volume down helps a little bit as well.
Yeah. Because the volume is just getting.
Right. And so I can also ask the question to first. Let me know. Where should I pick up your so
Whenever you're ready, Councilmember.
where am I? Number 11. Yeah, I can help you. Okay. Would you like to start? Would you like to start reading? No, just tell me where that was. Oh, you're right here. You're right here. Okay. Number 11. Regarding the newly announced in the last one vending machine. Are you there, council member?
I am Councilmember Gray. You can go ahead and start whenever you want.
Okay. Regarding the newly announced naloxone vending machines, can you speak to when this program will actually officially kick off? When it will start?
Yes, first of all, good afternoon, Councilmember Gray. It's a pleasure to see you. And I can, in fact, I had the opportunity of really being at the kickoff a couple of days ago, along with FEMS and DC Health. This is a DC Health program where they have entered into agreements with 2 providers to have the naloxone vending machines. The first machine, which will be at fire station number 7, will be open on the 10th of April. And in the machines, they will be able to, individuals will be able to, with a pass card, they'll be able to go up to the machine and they'll be able to get naloxone, wound care, and other health supplies. It's really exciting to see that. And there'll be a total of 6 throughout the community.
Okay. Is there a reason why nearly all of the states, the efforts to do this, to get this underway, are at fire stations, which could deter some people from accessing it and not being able to directly connect with community hotspots?
Well, I first of all, as I said earlier, this is a DC Health initiative, so they will have much more detail about the planning process and those decisions. But I can tell you, the one that I saw was outside of the firehouse on the street. And so people could come by at any time. It wasn't inside the firehouse. And that was specifically done so that there could be great access. The boxes are temperature controlled, and they actually send a message to the provider when the supplies are low so that they can be replenished immediately.
I see. I appreciate that. Why is DVH educating the community on these avenues of naloxone availability? Can you speak to that, Dr. Bazaran?
Yes, sir. As you know, we have a public communications campaign that has been going on for I think years now, a couple of years now, that's really designed to push out the messages around the importance of naloxone, having people ready to save a life. You may have seen our Ready campaign. And it's also, I've done a number of press events and demonstrated the use of naloxone, which have been shown widely on TV and also on radio. And also when you go to the gas stations and you look at that little window, I might pop in and talk about naloxone. So I think we have a fairly comprehensive campaign we take every opportunity possible to push out the word at community events and any other venues that are possible, that are available. Like the Chuck Brown event.
Okay,
We're there, we're there with our van, the huge van, and we talk about naloxone and fentanyl strips.
mhm. The latest version of Long Live DC report is from August of 21. When if at all will there be will the mayor be releasing an updated report, Dr. Bazran?
Our goal is to release an updated report by August 31st, 2023, which is International Overdose Awareness Day. And already we have begun, starting back in January, gathering new strategies and activities from all of our stakeholders, which amount to about 900 people across the city. So we've been gathering lots of information and meeting monthly with them to create new strategies.
The the capital budget includes funds for a second sobering center, which is that being released now?
The RFP has not been released as of yet. The second sobering center, we do have funds in the FY24 budget for the full build out of the center. Operating funds are not included in the FY24 budget.
Okay, and what do we need to do in order to try to effectuate that relationship going forward, Dr. Bazran?
Well, what we will do is once the center facility is prepared and we are closer to knowing when it will be ready for operation, we will be letting a request for a proposal from members of the community to apply to run the center. This will be operated by a provider and not by the Department of Behavioral Health.
The capital budget includes a second sobering center. Is that still effective? Is that still set to be is that still set to happen, Dr. Bazran?
Yes, the 9.5 million that is in the capital budget is for the second sobering center that will be located at the firehouse. And we will use those funds to ready the facility.
Okay. The capital budget includes funds for a second sobering center, I guess, which I was glad to be able to see that's going to be released. What is the timeline for that, Dr. Bazran?
When do you say it again, please, sir? When?
The timeline for the
the timeline.
second sobering center?
Yeah, we have not developed the specific timeline for opening at this point. We are now just at we just now received the funds so that we can begin the facility development process. And
Okay.
we'll have to then move forward with that shortly.
Okay. All right, Madam Chair, I'll just turn it back over to you at this point.
Thank you, Councilmember Gray. We've been going for about 2 hours now, so we're going to take a short break. And then we'll come back and we'll finish up. All right, we'll take a 10-minute break.
Thank you, Madam Chair. I asked you about the 700,000 dollars. Yeah.
Okay, and we are back. And we're back on 10-minute rounds. Director Bazran, I wanted to start this part by talking a little bit about state opioid response. You were talking a little bit in some realm with Councilmember Gray around the vending machines, the Narcan, fentanyl strips, all of those things. We see that in the FY24 budget includes $2.5 million for recovery activities, including 4 peer-operated centers and recovery housing. Is this a new program or an expansion or continuation of existing program?
That's a new program that we're offering so that we can get and really it is a recovery housing model. We're using the National Association of Recovery Residences standards for that model. And it is to provide a sober environment for individuals who are in recovery to live. We have 2 providers. There's a total of 13 slots. And the providers are really responsible for ensuring that the individuals have the treatment services that are required, the psychoeducation treatment services that are required. And also, thing I think that's very important is that this really follows along the principles of harm reduction. So in many instances in the past, recovery residences would eject individuals who started using while they're in residence. In this instance, they cannot do that because we do believe in the fact that substance use is a chronic and relapsing disease. And we also believe that in Prochaska and DiClemente's change model, that this is a change process. So.
Okay, so you said that there are 2 providers with 13 slots. The budget shows for 4. Are we increasing?
No, go ahead.
The budget shows for 4.
Or at least the
Yeah.
description we have maybe on the budget books is for 4 peer-operated centers and recovery.
Oh, that's
No, that's peer
different.
operating. That's different.
Okay, all right,
The
so,
recovery houses. Mhm. The peer operated centers, we have 4 peer operated centers.
okay,
Each one covers 2 wards.
okay, and then you have 2 providers for recovery housing,
Correct.
and together it's 2.5 million.
Yeah, we also have Oxford houses.
And
that
we have,
fund.
yeah, right. Oxford houses, Oxford will bring on 3 additional houses.
So Oxford houses will open 3 additional. In addition to what, how many do they currently have?
They have what, 32 now?
Okay. All right. I'm sorry, you mentioned that they would cover, the centers cover 2 wards. Which wards are those?
Each center covers 2 wards. It
Right.
depends on the respective center in terms of which 2 wards they cover. Sharon, do you want to?
They have,
Okay. This is great, why we all take algebra. I'm doing the math in my head, forgive me on that. Okay, let's talk about the Office of Opioid Abatement. So as you know, the Opioid Proceeds Amendment Act of 2022 is now law.
Mhm.
Yay, Congress did not interfere on that. My understanding is that, well, this was asked in another hearing in Committee of the Whole today upstairs. For whatever reason, the CFO never included that money in the financial plan that is anticipated to be in that fund. So I guess my question is, when do you anticipate being able to establish the Office of Opioid Abatement?
Well, first of all, I'd like to say that the district, as you know, will receive $49 million over the next 18 years. The first amount of allotment of funding is in the district, but was placed in the DC health budget. And so we have now entered into a memorandum of understanding, and those funds, and it is fully executed as of April 4th
Okay.
of 2023, to be specific.
Yeah. Great timing.
And $6.8 million is contained in that fund, which will be transferred to the district. In the law and in the requirements, funding is to begin being used in April and in the last 2 quarters of FY '23. And so we are awaiting that money so that we can hire the 4 positions that are within that program who will be responsible for implementing the fund. In addition to that, it is a requirement that the Opioid Abatement Advisory Commission be stood up.
Yep.
And that will be the Department of Behavioral Health's job. And there are specific constituencies that must be included. And so
Yes.
what I'll be doing over the next few months is really eliciting the potential representatives for that.
Okay.
And then we hope to have the office stood up certainly by the end of this fiscal year so we can move forward.
Okay, so let's break down a couple of things. So one, in terms of the advisory council, when I look at the membership makeup of it, we could reach quorum with just the people from the government. You, me, Wayne, someone from the chairman's office, Dr. Lewitt, those types of things in
Sure.
order to get it going. What I don't want us to get to a point of is that it's October and this group has never met. And so
No.
the money is just sitting.
No, that is not my intention. Here
Okay.
again, step 1 was having the money transferred.
Okay,
And so, as I said, as of April 4th, we have now set up the process for that.
okay. So is the money always going to flow to DBH and then
It
come
will flow-
across?
in the future, it will flow to DBH since we are now.
Okay, so this MOU is only for FY '23 purposes.
So a moment of clarity, Dr. Basson is right. We did finalize an MOU, and under the former financial system, when we transacted an MOU, we would have to transfer the funds from one agency to the other for budget authority. Under the new financial system, we aren't transferring the funds from one agency to the other. A project structure will be set up so that DBH can access the funds within DOH.
Oh, so say that again. So DBH will be able to access the funds within DC Health.
Yes, exactly.
Okay, so the fund will never show on the DBH
On
budget.
our ledger.
Unless there are future conversations to discuss making sure that it's loaded in DBH for FY '25 and beyond.
Okay, okay. That seems a little convoluted, but we're gonna let it ride for the moment, because if your office is responsible for the chief opioid response of the district, then I feel like that fund should be sitting with you and not DC Health. Love DC Health and the work that they do as the public health agency, but this is much more specific. But let's talk about the 4 positions and FTEs.
Mhm.
In your current budget, outside of the Office of Opioid Abatement, do you not currently have staff that
No.
currently work at DBH who work on opioid response?
No, not for we have people who work on opioid response, but not people who are would be devoted to this new opioid abatement office. In this office, there's to be a director, a grants manager, a program analyst, and a staff assistant, simply to focus on the projects that come through this particular office. However, we
Would
will
there not be
make sure-
overlap?
However, we will make sure that there is close coordination so that we're not duplicating efforts and so forth with our state opioid response.
Okay, I just feel like we would be duplicating, because in this scenario, an organization, let's say Christina's running a CBO, I can go to her office and then I can go to the Office of Opioid Abatement and apply for grant funding
Mhm.
to do the same thing, no?
Yes, you could, but then once we get the recommendations, then it's so from what is the best way to fund the particular recommendation? If it's something that, for example, I assume you're talking about SOAR dollars,
Mhm.
and it is consistent with the framework for the opioid settlement funds, we could make that decision so that we can maximize the funding that we have available.
I'm all about maximizing the funding, and I'll be transparent with you. I want us to use the settlement funds so we can free up local dollars to do other things. And so if we are double dipping, in my opinion, then that doesn't necessarily get us there. I'm curious about efficiency sakes here of the department essentially having 2 opioid offices, roughly working with the same populations, roughly working on the same activities and things. But I'm over my time. We'll come back to this. Councilmember Gray?
Thank you very much, Madam Chair. Malcolm, yes. Hang on, Madam Chair.
I'm great. It's all you, Mr. Gray.
Last year, I worked with you and the chairman on a subtitle that would address a rate study for the school-based mental health program, which was due last December. Can you explain what delay has occurred and why it's happened? Just tell us the best you can. When can we expect the report to be forthcoming?
Yes, sir. Thank you for that question. The school-based behavioral health rate study has been delayed, and the major reason for the delay was our inability to get the information we needed from the community-based organizations. We didn't want to make some determinations about rates without having the cost and the expenditures that the CBOs currently are experiencing. And it took us quite a while to, quite frankly, get the information from the CBOs. And still to this date, we still have 2 CBOs who have not actually provided that information. And so that's a part of the delay. However, now we have enough of the information that the analysis can be done. The evaluator is currently working with the data, and we expect to have something within the next month.
Okay. Can you explain as succinctly as you can when the substance of the report will be available to us, Dr. Bergeron?
The subsequent report we expect to have within the next month, within the month.
The next month?
Within a month from now.
Okay. And that will be available to be disseminated to the committee at that point?
Absolutely, absolutely.
Okay.
Mhm.
All right, that'll be wonderful. I appreciate that, and if there's other information that will be available to us and the committee, I would appreciate that, Dr. Bergeron.
Okay, if there's other information that the committee would like to have, we'd be happy to share that with you.
Okay, is there anything in the rate study that you can share with us at this point?
At this point, because the analysis is currently underway, I really don't have any findings to share.
Okay. Can you explain, Dr. Vazron, when you'll advance the school-based mental health study with the proposed budget associated with it?
Yes, the school-based behavioral health budget. Are you speaking of the evaluation, sir?
Yes,
Yes, that will be prepared and ready within a 1-month time frame.
okay, within 1 month?
Within a month, yes, sir.
Okay,
And that will be a qualitative assessment of the program as well as the quantitative and the financial aspect of the program. So both pieces will be contained within that document.
okay, thank you, Dr. Vazron, I appreciate that very much. I think last year's proposed budget reduced the amount of CBO grants and clinicians and clinicians involved in the schools.
Yeah, no, sir, we did not reduce the amount per clinician. As a matter of fact, it was increased to 63,153. And in addition to that, we had $1,000 for professional development to pay for any licensure or fees or exam prep classes that they had. We also provided supervisory support, which wasn't directly in the salary, but there was another 16,667 so that they could get free supervision if they needed those hours for licensure. And we also provided some one-time funding in the amount of 28,037.
Okay. Do you think that compensation is a problem for us being able to engage the young people or the people, professionals in our schools, Dr. Vazron?
No, I do not believe the compensation is the issue, because remember, the money we provide, Mr. Gray, and I know you were there at the very beginning of the school-based behavioral health program, was to pay for prevention and intervention services. And
Right.
so now we have the 63,153 plus the additional funding that we are providing for clinician salaries next year, which include money, some one-time funds also. I don't think so. And what we know is that essentially the providers are paying, somewhere around 70,000 on average. And remember, we were to pay 50% of the salary, and the 63,153 really exceeds that.
That's right. Thank you. I appreciate that. Can you tell me more about the expanded services for the child and adolescent mobile psychiatric services team, Dr. Vazron?
Certainly.
And go right ahead.
Certainly. One of the things that we have the CHAMPS mobile crisis team, which is the child and adolescent mobile crisis team that responds when there are crisis issues in the community that children and their families face. However, one of the changes that we made is that During the evening hours, we wanted to make sure that they had 24/7 coverage. And so we now have merged that service with our crisis response team, our adult crisis response team, the CRT, so that the families will be able to get response quickly 24/7.
Okay. Can you tell me any additional information about the child, the adolescent mobile psychiatric services team, Dr. Bergeron?
In terms of the CHAMPS team, we
Yes,
do- we do
yes,
have
exactly.
we have a provider that will go into the home and work with the family to resolve the crisis. Our goal is to keep the young person in family and in community. And so sometimes they're there for quite a long time. We also know that in some instances, if a family member calls for a crisis team, it can be resolved over the phone by providing some consultation support to the family. And so that service has been up and running, has been very successful over a period of years, and we continue to make that available.
Can you tell me
And-
whether DBH is budgeting for expansion of the team, Dr. Bergeron?
Expansion of the community response team.
Yes.
Yes. Well, right now, if you look at where we are really trying to hire staff, additional staff for the community response team. We do have those positions in our budget. We now have 44 staff, and we will hire up the number of staff to 60 staff, 60 some staff. And so we are feverishly hiring.
Okay. All right. Thank you. Thank you very much, Dr. Bergeron. Thank you for all you do. We appreciate it very much. And Madam Chair, let me turn this back over to you at this point. My time is up, so thank you very much.
Thank you, Councilmember Gray. All right, Dr. Batsaron, let's go back to talking opioid abatement response. So looking at the proposed budget, it is showing that for state opioid response, you all are increasing FTEs in that division by 7.5. Is that accurate?
For the opioid response program?
Yes. The budget book says that you currently have 13 FTEs and that you are proposing 20.5 in state opioid response.
Yes, that is correct. We are adding FTEs so that they are reflected in the FY24 budget that were not reflected in the FY23 budget. Sometimes our federal grantors will send us awards that will allow us to fund FTEs, and they'll send us awards after budget formulation for that fiscal year. So because we received the award and authority to fund those FTEs, they wouldn't have been included in FY23 budget formulation.
Okay, so how many of so are you saying that right now, today, FY23, you all have the budget authority to hire 20 people for state opioid response? And that the budget book for FY24 is just catching up?
Yes.
Yes.
Okay, how many vacancies do you have in state opioid response?
I need to look at the vacancy report that we sent to council on March 22nd, and then I can get that answer for you.
Okay, the next question I would have, and we could do this as a follow-up, is for each of those positions, how are they funded? Is it local or is it federal?
Yes. The summer short funded.
If that's okay, we'll include that in the follow-up if we can get that information from you all as well. I am there will be a process where I have to go back and like defend what we did in the committee budget to my colleagues. And there will be a question around what is the difference between the state opioid response office and the Office of Opioid Abatement, and
Right.
why we need two different offices who are working on similar things with similar grantees. And so I think we just got to get some clarity on this in the next couple of weeks of what our plan is, if that's okay with you, Dr. Basil.
Yeah, and as you know, this bill was passed by council, and one of the things that is unique to the opioid abatement office is that they will be able to fund infrastructure, and we have no other way of doing that. And in the past, I think that there were other abatement funds that came to the district at other departments, and most of that went for funding infrastructure,
Mhm.
so that the facilities in which treatment is operated looks like what you would like to have if you were going there for treatment.
Right. To what extent are you talking with the Office of the Attorney General about the funds and then the future use of the funds? They were the ones who flagged for us that a concern, if you will, that we are not ready to spend it as soon as we get it. And so, you know, obviously they have an interest because they were the ones who
That's right.
were part of the suit. And so we want to make sure, number one, we're meeting the terms of the settlement agreement,
Correct.
right? We don't want to spend the funding in a way that,
That's
you
right.
know, would get us in trouble, et cetera. But we also don't want to just have the money sit, especially as we have challenges, as you know.
Right.
Okay, so let's talk more about that part offline. I want to talk a little bit about before I get off of substance abuse disorder. There's a question I had from Councilmember Lewis George. So she says, we've heard from residents across the city that needles and drug paraphernalia are ending up on their properties, in alleys, at schools, and on sidewalks. What training, if any, is DBH providing on safe collection of those items to either DPW, DSLBD clean teams, or even the maintenance or custodial crews for DPR and DCPS facilities?
Our syringe service programs are always willing to train anybody in the safe collection. They actually have on hand collection boxes that they can give to folks. We, like, for instance, in Noma, we had an issue with syringes down there, and working with the Noma bid to put collection boxes there so that their teams don't have to pick them up. And anytime that there's a cleanup needed, our teams will go out and do the cleanup. We have now, DBH just took over the syringe service programs in January. And our coordinator has now assigned the syringe service programs to different quadrants in the city, even though they serve, many of them serve, or most of them serve the entire city. But when there's something like a cleanup is needed, they know, you know, like HIP's assigned to the pet birth area, that is their jurisdiction, and family medicals down east of the river. So they're willing to go out whenever the need is to call, and they'll train people to be able to pick up syringes. But we hope others don't have to pick up syringes, because our teams will go out and help with that.
Okay, so is there a number that, I guess the better question is, how would they get in contact with the syringe team? Who should we be telling them to reach out to?
So that's a very good question. We have a general naloxone email at DBH, and that's what we've been using. But if it depends on who it comes from. If it's a council request, it goes through DaVita.
Sometimes it comes to me.
And it really depends on who
Okay.
the request is coming from, but we can look at potentially setting up an email address for
Okay.
specific for that.
This seems a little bit different than going through 311. No shade to the
Oh, yeah.
311 team, but you know, if, for instance, a school leader whose playground has public accessibility is noticing, oh, hey, we need to get this cleaned up before, students come out for recess. It would just be good for them to know who the access point is for them to call, whether it be them or the custodial folks. And so however you all want to do that, we're happy to disseminate that information. But
Yeah, we have a coordinator, but we wouldn't want her to be inundated. So we would have, just like with our naloxone, anytime there's
Yeah.
a request for naloxone training or anything, it's going to a central email that someone is checking daily and multiple times a day. So we could look at that.
Mhm.
okay, great. All right. Gambling addiction treatment. I don't know who that is. We had someone testify at the public hearing. The 200,000 for gambling addiction treatment in the FY22 and FY23 budgets went unspent. Curious in terms of why DBH didn't select a contractor to provide these services.
Well, actually, we don't need a contractor to provide the services. Gambling addiction is a Medicaid billable service at this time and has been since 2021. Gambling is, there's a DSM-5 diagnostic criteria for this level of care that really focuses on the persistent and recurring problematic gambling behavior that really leads to impairment and distress. And also the need for increasing the amount of money that's gambled over time to get the same desired excitement. And so that is already in place. Reimbursable, we have reimbursement for screening, assessment, behavioral health counseling, and therapy services. The providers who are qualified to offer this service are physicians, OLP certified addiction counselors, FQHCs.
So Dr.
Yeah.
Bowser, are you saying that the 200,000 wasn't necessary because
Well,
the activities could be covered?
actually to provide the service. Now, one of the things that we certainly will be doing this year is providing some training in partnership with the National Center on Problem Gambling, on Excellence in Problem Gambling, to our providers, just to ensure that they are aware of the approach to this.
Okay, so you would cover the training in-house through your budget? My understanding is that money has been spent.
We have funds to do that.
You have funds to do the training for gambling addiction. Okay. All right. We're making our way a little. Let's talk St. Elizabeth.
Okay.
Let me just say at the outset, I've been on a hospital tour, and technically St. Elizabeth is a hospital. So I would love the opportunity to
Certainly.
come see the facility.
Sure.
We could do that after the budget, but I would love to. I have technically 3 hospitals left. You all, UMC, and technically Children's, although I've been to Children's with my own children, so I don't know if I need to see Children's again. Okay, so in the FY 2020, oh, I'm over my time. Hold on. Hang on. Councilmember Gray, do you have any further questions for Dr. Bazran and her team?
No, thank you, Madam Chair.
Okay, all right. Thank you for being with us today. Okay, so the FY24 proposed capital budget includes 2.6 million for St. Elizabeth's facility projects. How will this capital funding be spent? And if you all can please provide as a follow-up a detailed spend plan, but happy to hear
Yes.
what you guys have
Good
planned.
afternoon.
Good
Yes, Good
afternoon.
afternoon. Yeah, so now that the prevalence of COVID is past, contractors can return, we can get at a number of projects that were delayed. And so we've got all kinds of needs and projects underway, and those that will be underway very soon. And so these funds will be used for roof repairs.
Okay, so
And-
small capital type projects.
Yes, a variety of. And
Okay.
so we have the floor replacement going forward. That's now back in full progress. Over 4 units have been done. A second project is a thermal docking station, an upgrade of our dietary services.
Okay.
And that's moving forward. And a variety of modernization of our HVAC systems, repairing and upgrading our cooling towers, as an example.
Okay.
Putting in, so those kinds of projects are moving forward now that the pandemic has declined.
Is 2.6 million sufficient? Because when you mention an update to HVAC and cooling,
Yes.
I know what the HVAC and cooling for some of our high schools costs. And so 2.6 seems low to cover that plus all of the other projects that you described.
Yes. So we'll be back in 2025
Okay.
and 2026. So there's an ongoing need, of course, to maintain a 24-hour operation
Okay.
such as ours. So annually, we'll be back before you with our needs for the respective.
Right.
budget
In
periods.
addition, council member, we do have money in our FY 23 budget for some of these capital activities, and these funds can roll over. For example, we do have money for HVAC, and there are projects underway. We have a total budget of about 1.8 million for that. We also have money for other things like our intercom system, our thermal docking station, which also are in our existing capital contract. So we do have some funds to support.
Okay. The budget includes 2 one-time enhancements in the exact same amount, $544,933 for separate programs out of St. Elizabeth's to quote, support inflationary adjustments for patient medication and nutritional needs. I totally understand inflation costs, but I'm confused in terms of how you all determined this particular amount. Are these reflection of increased costs for specific contracts related to medication and nutrition?
Yeah, so there are increases related to inflation. That's a component of it. There's also a component with the hospital returning to pre-pandemic operating admissions numbers. So our admissions are increasing. The cost of medications and food have increased as a function of inflation increases. So
Okay.
these are estimated.
But the exact same number for both lines. So I'm gonna pull out my calculator because I'm not great at math. So I'm just gonna, let's see what it is if we add them two together.
So that amount was submitted when it was placed in our budget. It was divided between pharmacy for medications and food for nutritional services.
Mhm.
And we may need to move them back and forth. It is not to the penny of 50-50.
Okay.
There were 2 areas involved in the enhancement.
Okay, it would be nice if we can get the actual numbers. I like to just be clean across the board, so we have very minimal reprogrammings. So if we are on the council side, going to be inputting the numbers, it would be nice if we could just put the money in the right place. So if you guys can get us the right numbers, that would be great for us to know. Because, you know, it's $1 million and some change. I just want to make sure it gets to the right place. But that was suspicious that it was exactly the same amount of money. Speaking in terms of returning to pre-pandemic capacity, what number are you currently at?
We're at 225 patients today. And our goal, and we're moving toward that goal quite nicely, is to be around 250, 260 by the summer of 2023.
Okay,
Average daily census.
all right. And so the FY24 budget reflects the idea that we will get to 250, 260, and we'll have that for going
Yes.
forward. Okay. We've heard some concerns around the residency program, the psychology residency program over at St. Elizabeth's, and that the residents are paid less than individuals in other residency programs at facilities or agencies or hospitals. What's the salary for psychology residents at St. Elizabeth's?
It's low compared to other organizations, but that is being negotiated and something's being done about that as we speak. The
Negotiated, would they have a union?
contract negotiations under our current new union negotiations is underway as we speak.
Okay.
To
Right.
respond to that issue.
Is funding set aside in the workforce investment fund to fund those salaries once you come to a contract agreement?
Yes.
Mhm.
Okay. This is a hard question to ask, and you may not want to say it out loud, but are we close? Are we not close? I was just curious.
Progress has been made.
Progress has been made. All right.
Right. And Madam Chair, I would like to say that, this is a collective bargaining issue, and LRB is really leading the way.
Oh, no, I told, that's why when you said it was a
Right.
contract issue, I'm not even gonna go further on there. That was the only thing I wanted to know is if we set the money aside in the workforce investment fund so that if you reach an agreement in the next 5 to 6 months, those pays can be
But here
effectuated.
again, it's a part of the collective bargaining process that happens centrally.
Okay. So that's for the residents. My understanding is that the psychologists at, for DBH.
They're also within the general.
Okay, so their contract
Process.
expired in 2021. For the psychologists.
There are no employees without a union contract. Yeah, it does. If they're in the midst of negotiations, the existing contract continues until the new one goes into effect.
No, that, I understand that. I guess I'm just trying to understand, are the residents and then the actual psychologists under DBH under the same union contract?
Yes, the residents are under a union contract, which is comparable, which is being negotiated centrally. Is that what you mean?
Okay, so you have a resident and then I have the full psychologist. I'm not a resident anymore. Are they in the same union?
Yes.
Mhm.
Do they have the
Yes.
same contract?
No.
No,
Okay.
they're different.
So you say you are currently negotiating the residents. What is happening with everybody else?
Both.
Both. Okay, so we're,
Psychologists, the residents and the clinical psychologists, union contracts are under negotiation as we speak.
okay, so everybody.
That's
Right.
correct.
All right, great. Okay, let's talk mental health, community residential facilities. I learned something very interesting yesterday from healthcare finance in that they don't cover room and board under Medicaid. That's all y'all, which was, this healthcare stuff, it is sometimes complicated in terms of who does what. The proposed FY24 budget, your budget, has includes $18.1 million to support mental health community residential facilities. Individuals living at these facilities use their monthly supplemental security income, personal needs allowance to pay for food, shelter, living expenses, and they are permitted currently to keep $100 per month for personal expenses. We've been having this conversation about P&As, and I know we've raised, well, this budget, not on yours, I think it's in DDS, doesn't a proposed increase in terms of the P&A for individuals with disabilities. But we haven't seen an increase in the P&A for everyone else, and particularly for those who are in more independent living or group homes or those kinds of things. So I'm trying to understand, we've heard lots of testimony from folks who say $100 is not enough. How can we get that number up to reflect that folks need to pay for a cell phone or clothes or, other items?
The $100 is the amount that the actual consumer gets to keep out of their Social Security check.
Right.
And for personal items. And the Director Byrd and I have been talking about that and how we might be able to, what we might be able to do. But that's for the person,
Right, that's what I'm talking about, for the person.
for the individual person.
Because some providers or even case managers, outreach folks will say, yes, I know someone who needs the services of a mental health community residential facility. But when I tell them that they only get to keep $100 of their social security check, they decide, this isn't for me. And so I think 100, like that, just on its face, it's low, especially for the cost of living in our area. Okay, but we don't have it. Well,
At this point, I don't have a response. As I said, that's something that DHCF and DBH have been discussing, and we'll try to find a pathway forward.
okay. I wanted to ask about a different set of facilities. Sort of going a little bit back to substance abuse disorder. So SUD residential providers. I think we're down to 4 remaining in our program. Is that concerning to you to get down to?
Certainly, and we actually, Dr. Moise is looking at how to recruit additional providers within our community.
Okay, is it a reimbursement rate problem? Is it something else?
I think that it's a combination of issues. The other thing to note is that all of our residential providers worked under kind of the, for lack of a better way of describing it, the therapeutic communities model, where somebody could go in, they could stay for 28 days, they received a rate. That was when this service was being funded solely through substance use block grant funds, period.
Okay.
Now we have moved that to the ASAM criteria, the American Society of Addiction Medicine criteria. And so now people have to meet medical necessity criteria to remain in that level of care. So it's no longer they'll be there for 28 days. They may be there for less. They may be there for more, what have you. And so helping the SUD providers really move to this new model is one of the issues that I think we're finding. And we're working very hard with them on doing that, as well as helping them to develop additional IT systems that we think will make their processes a little bit more efficient, and providing them with revenue cycle management training and information. I don't know if there's anything else you want to say.
Okay. Staying on talking residential, the mayor's proposed FY24 budget includes 1.7 million, an increase for new person-centered intensive housing case management program. Who's eligible for this program?
Well, I think that's a great question. We, quite frankly, right now are working under the leadership of Deputy Mayor Turnage to really craft out a protocol and a model for this particular population. And I want to talk a little bit about it. These are individuals who may be living in the community in scattered site housing, but may have some challenges in terms of being able to live successfully there. And so these funds are really to provide some specialized case management and other support services to help them maintain community tenure. We're working very closely with the Department of Human Services, and with the Deputy Mayor's Office, and with the Housing Authority to develop a process.
Okay, so will DBH run this program in-house, or will it be contracted out?
Yes, the money is in our budget, so we will be responsible for managing the program, and how it is run and what those elements are will be determined as we begin to develop the protocol.
Okay. So I know that on the housing side, in terms of like DHS's community-based providers who do case management work, they're struggling to hire people. So how will this be different than what we're currently seeing?
Well, The way it will be different in terms of the service delivery is we will be providing, for example, and this is preliminary because here again, we're in the midst of discussions. But one of the things that we've talked about are things like making available landlord-tenant mediation services, using evidence-based practices like the critical time intervention model that was particularly designed to help people who are moving from homelessness into housing, making sure that they have close and connections with their provider if they need one. Those sorts of on-the-spot services 24/7 to help them. Those are just some of the basic, very, very broad parameters, but we have to really work as a group to develop.
No, I understand that. And I appreciate you sort of detailing some of the services. I'm just trying to understand how you're going to find the people to deliver said services, because we know that organizations have struggled to find folks to be case managers. I don't know, 1.7 million, how many people does that even get you?
Well, if you figure, you know, what, 70, 80,000, you can probably do the math and see how many people. However, we will have a full court press because we think that this is a critical service.
Okay. So is and I know you say you're still building it out, but so I guess is the intention that this will go into effect when? October?
Well, the goal is we have these funds beginning in FY 24. And so we are now doing the planning process with our partners. And so I would anticipate our launch would be during the next fiscal year.
Okay. How many people are you hoping can be served?
Here again, it depends upon the approach that we lay out and the program description. I can't tell you that now.
I
I'll be able to
understand.
give you more information once we get a little further along.
I know, but this is one of those situations where then like, I want to trust you. I do, but we approve the 1.7 million and we have no plan for said 1.7 million, not even a sketch on a page of how many people this is going to go to. What are the services that are going to be provided? Here's the timeline that we're looking to do. We need that type of justification to say this program, one, is going to launch, and two, is going to be effective in terms of what you're trying to do. But right now, I don't have anything to go from except for a bullet point in the mayor's presentation that this is something that she wants to do. And that's not just you. There are other programs throughout this budget where it's very scant on detail. So I know you were talking about CHAMPS a little with Councilmember Gray. I want to ask, there's a proposed in the budget, it includes a $260,000 reduction in temporary staff contracts in the Community Response Division. What was the work being done under those contracts, and will that impact service?
Are you talking about CHAMPS or are you talking about CRT?
And now I guess I'm talking about CRT.
Yes. And so we now have permanent positions.
Okay.
And so that's the response.
All right. Okay, and then there's a proposed reduction of $500,000 in contracts within child, adolescent, family crisis services. What were those contracts being reduced?
And the issue there is that is a billable service. And so they will be able to bill for that service. And also remember, in addition to that, they will be, that service will be covered by the CRT, by our crisis team, our adult crisis team.
Okay, does the crisis team have any staff that can engage with children and youth?
Absolutely. One of the things that Dr. Bebout is looking to do is hiring specific staff with child expertise. That was a part of the program.
Okay, so when you say that's a billable service, sorry, going back to child, adolescent, family crisis services, is that to say, once we reach our cap, we're done? I'm like,
what?
To reduce that contract by, or that contract line by 500,000, I want to make sure that we still have enough money to get the services that we need.
Yes.
But you said that's a billable service.
It is. It's a billable service. However, you know, the contract is still fairly substantial. And we have been working with the provider to ensure that all services can be delivered within that framework.
Okay. Is Champs that provider?
No, the provider.
Oh, someone
and the
different.
Charities.
Okay, Catholic Charities, okay. All right. I've asked. Sorry, just making sure we've covered all due diligence here. Oh, we talked about this at Performance Oversight, the Live Long DC website. Are we updating that in FY24?
That's a plan.
All right.
That's the plan, yeah.
Okay. If we could get those reports that you all have worked so hard on up on
Yeah.
your website, that would be really great. One other thing. So yesterday we had a provider who testified at the healthcare finance around the MCO transition.
Mhm.
And one of the things that she mentioned and brought up was two things that haven't necessarily, that she said hasn't been communicated to providers. One is what services are transferring? Are all the services transferring? And then the second was what will be the cycle of payment? Because right now they are used to getting paid weekly. And I know that MCOs, they don't do weekly. But I think the concern that she's hearing from her fellow providers is that nothing is on paper yet in terms of what to expect. When do you anticipate you all will be able to provide that information to providers?
Well, first of all, there's a full carve-in of behavioral healthcare services. So all of our services will be carved in. Our MHRS services, our ASAR services, oh, sorry. Can't hear me. Our MHRS services, our ASAR services and our child and youth, all of our services will be carved in. So that's always been the intent.
Okay.
Because we want to move to whole person care. And the only way to do that is to make sure that the individual is getting both their mental health, substance use, and physical health care in one site. The answer to the question in terms of the billing and payment schedule, that's one that I cannot answer because it really is within the MCOs. But one of the things we are doing, and I said this earlier, and that is that we are providing technical assistance and support in terms of revenue cycle management to all of the providers so that they will have the ability to function effectively in an MCO. And that is one of the very important things that we've been working on hand in glove with the Department of Healthcare Finance.
Okay. Dr. Bazaran, that's all of the questions that I have. Let's just review the follow-ups and then I have a couple of things I have to say and then we can get out of here. Okay.
Excuse me.
All right. So, okay, so we talked about how we can disseminate the access helpline number and the mental health hotline numbers. I think there was a suggestion from Council Member Louis George of, how do we at least inform more young people around like, this is an opportunity and a service for you. We asked how many teen peers will be hired through the DC Prevention Center peer funding. And then a breakdown of the FTEs and frankly, all of the funding that's within the state opioid abatement division, or sorry, the state opioid response division, broken out by funding source. So who's federal, who's local, and then the same in terms of the contract line items within that
And so in the state opioid response grant, is that what you're talking
Yes,
about?
yes.
Okay.
And then the number of vacancies that currently exist from that. And then an update on who we should tell folks to contact around syringe cleanup. If it's an email address, let us know what that is, but that is what we,
On syringe pickup.
yes. And that is it. And if we have anything else, we will, is there something you wanted to clarify? Hold on.
It was text.
It's like telephone, but digital. It's all good. So that's all of the questions I have today. Thank you, Dr. Bazaran, to you and your team. We will most certainly be in contact with your AFO and teams as we sort of go through this. Sorry. The other thing that we would need is the breakout for the increases at St. Elizabeth, so we make sure that we have it in the right program lines, that 544,000, to make sure we get it right in terms of nutrition versus the pharmacy. Okay, so this concludes my questioning. If we have any additional questions, we'll reach out. If anyone would like to submit testimony who was unable to testify last week, the public record for the Department of Behavioral Health will remain open until 5 p.m. on next Thursday, April 13th. You may email your statements to astrange@dccouncil.gov or leave a voicemail at 202-430-6046. If you choose to do that, please speak slowly and spell your first and last name for the record. Our next budget oversight hearing for the Committee on Health will be for the public witnesses for DC Health, or the Department of Health, on Monday, April 10th at 9 a.m. The time here, though, is 3:17 p.m. and we are adjourned. Thank you.
Thank you.